Welcome, everyone. Please put your name and facility in the chat. We're going to wait a few more minutes and then we're going to go ahead and get started. So welcome. You're just joining, welcome. Please put your name and facility in the chat. And I'm just going to continue admitting people and then we'll go ahead and get started in just a moment.
Hey, Tiffany, I'm checking my mic. Can you hear me okay? Thanks, everybody.
All right. Welcome to the August KPQC Learning Forum. I'm Tiffany Burrows. I will monitor the chat if you have any questions. And I'm going to continue admitting people and I'm going to actually mute myself and I'll turn it over to Carrie and Tara to get us started.
Hi, everybody. So happy to have you in August. This is always the time of the year that I feel like the babies come in large quantities. And so I think the fact that everybody can meet at noon is amazing to me. The fact that you all take time, certainly to be educated in the middle of chaos is not missed on us. This is actually Carrie's big day. She's going to do a great job of hosting and entertaining you all and educating you on top of that. I just wanted to say thank you for being here and certainly here for questions. Also, a quick word to the sites that I am connecting with. I am individually emailing you all and getting meetings set up. We really want to help you directionally to make sure that you are making great progress within for a trimester and excited to connect with each of you. If you have any questions, reach out to Carrie or I. With that, Carrie, you're up.
Thanks. Well, good afternoon, everyone. And again, just like Tara said, thank you all so much for just taking the time out to join us today and to be available to hear the fun information we have to share. A couple slides that I just want to go over. As a reminder, participating in the KPQC collaboration is considered a part of what CMS's birthing friendly designation is looking for. So for any of you who are not already 4 trimester participants and you're considering jumping on with us, we would love to have participation from every facility within the state. And it's a bonus that it counts to help you in becoming a birthing friendly designation. Next slide, please. In addition to that, we have currently, just as an update, 1 birthing center and 2 hospitals that are on pause. So I think that just speaks testament to the fact that there are a lot of us who have a lot going on, and to the reality of what's the word I'm looking for? Hospital or birthing center deserts. You know what I'm trying to say. My brain is going off right now. But it's a reality, and we all feel it. We feel when one closes down, how we take on the extra from those facilities. So we are hoping that this isn't a prediction of what's more to come. Next slide, please. Our rapid response is just to remind everyone who is involved that the seats that we purchased for the A1 post-birth education expire December 15th of 23. So if you're in the midst of doing that education with your staff, which we'll actually touch base on a little bit today, make sure you complete it before this deadline. And for those who have just joined, just want to give you a quick incentive to get on board with that as quickly as possible before we lose those seats. Next slide. Also, another reminder, the Birth Equity Summit Save the Date is coming up September 15th and 16th. So if you get the opportunity to participate in that, that website is there for you to go to and check that out. Next slide. In addition, this has been something we've been talking about for a while. We wanted to let you guys know that our KBEN, our Kansas Birth Equity Training, is being rolled out currently to Hutchinson and Amberwell, Hiawatha. There's a rollout plan for Stormont, Topeka. They're in the midst of trying to get that established at their facility too. If you are ready for that to be implemented, we know the champions have done it. And if you haven't completed it as a champion, please go ahead and do so. But if you're ready to, once you've completed it as a champion, get that rolled out to your staff, please reach out to Tara or myself so that we can get you on board and connected so that we can make that happen. Next slide. This slide I'm super excited for. We've been telling you guys about the Save the Date, but we have our flyer and our registrations ready to go for our October conference collaboration between KPQC and A1. So take this opportunity while it's up on your screen. There's QR codes there. Just pop your phone up there, zoom in and join that link to get registered. You guys, we have great speakers, some pretty exciting vendors that'll be there, just some really good information, and more importantly, an opportunity for us to all be, quote, at the table of change and hear what's being done around the state to help improve our maternal morbidity and mortality. Next slide. Lots of exciting dates to share with you guys. Also wanted to let you know that the Kansas 2023 Breastfeeding Conference will be held in Wichita this year, October 26th and 27th. And they've got a QR code for you to scan too, if you're interested in getting registered for that. And then this is just, we love to show these at every learning forum, just as a reminder of what's entailed in our 4th trimester projects. And this actually tees us up for what we're going to be talking about today. As you can see kind of on the top right-hand side, the small light blue box of the ED-OB collaboration. It's what drove the importance of us highlighting that component here in our learning forum today. But just as a reminder of all the pieces that are embedded within the fourth trimester project, it is no small bundle to tackle. So just be mindful of that. And then each of our facilities, next slide, that is enrolled have all received the report cards. If there are any updates that you need to share on your progress that you've made so far in all of those, please make sure you let us know as we touch base with each of you so we can get those updated. More of that, what's done versus what's coming, what we've done, like I mentioned, the A1 post-birth warning signs, our breastfeeding and entry level or the champion education for the Kansas Birth Equity Training. What's coming, embedding that ED triage question, have you had a baby within the last year, the KBEN training for your whole staff, ensuring that you've got your community resource list established, embedding your screening for social determinants of health for your patients, ensuring every patient has a postpartum visit scheduled, and then also that we have a standardized postpartum visit template. So just to highlight what's done versus what's coming. Next slide. Okay, I'm pretty sure we have some KCC members that are on the call. We've added a few slides on your behalf from Jennifer. So if Patricia or Alexis are on and wanted to kind of speak to any of the KPQC information that they shared.
Hi, Carrie. Thanks so much.
Okay.
I know I'm in a public space and my earbuds are a little wonky, so I'm wondering if Alexis is there. Alexis, do you want to pop off mute and introduce those slides really quick? We'll also share some details about our last, currently our last planned workshop, where a couple of the sites will about their progress and success related to maternal mental health screening implementation. So Alexis, if you're there, you want to pop in really quick?
Sure. Yeah, so this is the quarterly data that was submitted. Most recently, it looks like the patient count has gone up a bit since last quarter, and we're still pretty solid with the number of positive screens. Percentage wise, were there more slides that Jen sent?
There's about 8.5, and I'm happy to jump in on any of this too. I apologize. I didn't mean to completely throw it out your way, but
that's okay.
positive screens, absolutely, you're right. On average, about the last 2 years, it's been about 8.35% of the patients who've screened positive on maternal mental health or substance use. But yes, there's 5 slides, so we'll go to the next one.
Okay. Yeah, so it looks like we've gone up a bit in those screen for depression, screen for anxiety. It looks like those are pretty stable. I'm not so sure what the top 2 lines represent there. It's not part of the key, but
I think we just want to highlight that we did have a small dip in the screenings, but the rates have bounced back up. So that's telling us that the sites are doing an amazing job with training current and new staff and getting everyone in the groove that we need to. So great job, everyone.
mm-hmm.
Next slide.
Next slide. So there's 100% of positive screens were referred, which is amazing. I think that's the first quarter that we've reached 100%. So that's really exciting. Continuing to see high numbers of those screened for substance use, anxiety, and depression. Looks like those have been pretty stable over the last couple of quarters. And we've definitely come up from Q1 in seeing those screened for substance use. So that's really awesome to see. Yeah, I think that's a breakdown of the FTI sites. Seeing again, just stable screening patterns for depression and anxiety. And then, yeah, doing a great job with screening for substance use as well. And it looks like there was a slight dip in those that screened positive over the last quarter from 12.1% to 8.7%.
Awesome. Thank you guys so much.
Yeah, Carrie, and I did have one more announcement to share.
Yeah.
We are having our FTI workshop for September, which is happening. Let me double check the date. I believe
Is it September 27th?
It is September 27th over the lunch hour. Thank you. So
Yes.
We're really excited to hear from some different FTI sites who will be sharing some of the things they've learned in their practices and just how to best serve the perinatal population. So if anyone is interested, I'm happy to forward that calendar invite, and we're looking forward to seeing you guys there.
Awesome. Thank you so much. Well, I am super excited to have 2 wonderful speakers with me today. They're going to help to speak to what's going on with our collaboration of perinatal education amongst not just our emergency departments, but what we're doing around the state to make sure that we're getting our education out to our EMS facilities and things like that. So let me start with an introduction. Abby Weatherly happens to be a personal coworker of mine at Advent Health Shawnee Mission. She's from rural Western Kansas, graduated from Fort Hays State University with her BSN in 2007. She obtained her MSN nurse practitioner in 2013 and her DNP in 2018. She's worked in the emergency department as a nurse since 2009 and as a nurse practitioner since 2013. She's board certified as a family nurse practitioner and an emergency nurse practitioner. She moved to the greater Kansas City area in 2014 after working as an RN and NP at Hays Medical Center in Hays, Kansas. Her favorite project was implementing a CPOE order set and treatment algorithm for the care of the sepsis patient in the ED. She currently works per diem as a practitioner for Envision Physician Services, and most recently, she became our clinical nurse specialist of the ED here at Advent Health. Not just our main campus, but also that of Lenexa and our College Boulevard campus in February. She's presented at the Midwest Nursing Research Society Conference in Cleveland and Kansas City, at Magnetizing KC Conference, and nationally at the American Academy of Nurse Practitioners Conference. She loves sports, especially the KU Jayhawks, and enjoys traveling and spending time with her husband, an adorable beagle puppy. And I'm also excited to introduce you to another dog-loving friend of mine. Mallory Suffields worked as a registered nurse in labor and delivery since 2010 and has been at Overland Park Regional Medical Center since 2012. Here she served in many capacities, including staff nurse, charge nurse, maternal transport nurse, mentor, and preceptor. She obtained her BSN from the University of Kansas School of Nursing in 2010 and her Master's of Science in Nursing Education from Fort Hays State in 2017. She's currently pursuing her doctorate of nursing practice from Chamberlain University. In June of 2021, Mallory assumed the role of the perinatal outreach supervisor for Overland Park Regional Medical Center, and she's full-time and continues to develop their educational offerings as well as delivering exceptional educational offerings to those caring for birthing people and children across the region. She has a great enthusiasm for learning about all things related to the care of pregnant patients and is equally avid about sharing her knowledge with staff and outreach facilities. Mallory holds active certifications in inpatient obstetrics, inpatient antepartum, and fetal monitoring. She's volunteered with various organizations, including AWAN, Kansas section as chapter coordinator and the fetal monitoring course content reviewer, the NCC on the item writing committee, and as a consultant with the Amniotic Fluid Embolism Foundation. So I'm super grateful to have both of these ladies here with me today as we talk about what we are doing to ensure that information is seamlessly tied, not just within our obstetric departments, but also out within the community with our EMS facilities. Next slide, please. So ED and OB collaboration, the way it should be is that we're all in it to save lives. We share our patient population across the board in both departments. And just as I know very little about their patients, it is very evident that they also have that same fear and panic when our patients walk through the door. So next slide. So in case many of you didn't know, there's been a recent push to collaborate between those two departments. COVID for our facility had a huge impact on this as we tried to bring any OB patient straight to our unit in order to minimize their exposures in the main ED, as well as to reduce the burden that the ED staff was carrying just with the general patient population. In addition, effective July 1st of 2020, there were 13 new elements of performance, so our EPs, that became applicable to Joint Commission accredited hospitals. These new requirements were within the provision of care, treatment, and services chapter at the PCO6, 0101, and then the PCO6, 0103. And they were designed to improve the quality and safety of care provided to women during all stages of pregnancy and postpartum. So we've seen the statistics many times, but the US unfortunately ranks 65th among industrialized nations in terms of maternal death. And because of those worsening maternal mortality and morbidity statistics, the Joint Commission evaluated and determined the areas that were held to be the most, with the biggest potential impact. Those two areas were ensuring we had prevention, early recognition, and timely treatment for maternal hemorrhage and severe hypertension and preeclampsia. So that became the area of focus. Next slide, please. In addition, something that I wasn't aware of is that in that same year, in November of that year, the Emergency Nurses Association and A1 published a consensus statement. There are 15 components to that consensus statement, and I won't go through all of them today, but a few of them that really stuck out to me were what you guys see. If you'll click one more time for me, Tiffany. What you guys now see up in front of you. And that's just ensuring that the response time for obstetric emergencies are practiced and rehearsed by interprofessional teams in the emergency setting, that emergency obstetric and outside hospital emergency response systems collaborated to determine the appropriate environment of care for situations in which the OB patient presents, including antenatal, intrapartum, and postpartum settings. Also, that emergency nurses recognize the possibility that a woman of reproductive age, regardless of presenting symptoms, may be pregnant or may have been pregnant in the past year. That's to tee up our embedding that question in your emergency department screenings for all patients who come through. And then that education and training is provided for emergency and obstetric nurses, including common high risk and life-threatening obstetric presentations, early warning signs of maternal compromise, and protocol management. So these two components really drive much of what we at our facility strive to do in our collaboration between our obstetric unit and our emergency department. Next slide, please. So I'm gonna have Abby jump in here.
Okay, you can go to the next slide. Thank you for the wonderful introduction, Carrie. I truly am blessed to work with you. You're much more than a educator alone, and wear many hats, and I look up to you as a coworker and a mentor and friend. So I'm going to review some of the ED triage and OB triage algorithms that we have developed to try to take care of the best care possible for this specialized population. So when a patient presents to the emergency department at Advent Health, they present and we do a quick triage just to determine if this would be better taken care of, the situation that they're presenting for would be better taken care of in the ED or over in the labor and delivery area. So the key points, or if the patient is less than 20 weeks, they remain in the emergency department, and then we contact labor and delivery as needed. If the patient is greater than 20 weeks and has an OB related chief complaint at their presentation, and also they're stable, we can transfer that patient over to the L&D area for specialized treatment. If the patient does not have an OB related chief complaint and is greater than 23 weeks, we contact L&D for fetal monitoring in the ED. We have two links where we can monitor the fetal movement and status of the babies or the fetuses in the emergency department, and that is sent over virtually over to the L&D, where they can actually monitor that on their end and then let us know if something doesn't appear to be going very well or if there's any complications. Okay, this is an L&D triage of non-obstetric complaints algorithm. So if they present on the L&D side, this may be changing soon. I'm not sure with the new OBED that Advent Health is implementing later this month. But for now, it still remains the same. If the patient presents over to L&D, if it's not an OB related complaint, they transfer that patient over to the emergency department for that specialized care. If it is an OB related complaint, then they of course would remain in the L&D. And then if the patient is greater than 23 weeks, does not have an OB related complaint, again, we'll keep that patient in the emergency department, and then we'll contact the L&D to set up that fetal monitoring.
And Abby, we absolutely would love to still send those non-obstetric patients right back to you.
As we love to send OB complaints to you guys. So I think that's what makes this collaboration so special. You know, it's two very diverse, skill set that we have. It's very kind of polar opposite, but blending together we have a monthly ED L&D collaboration meeting set up that lasts about an hour. So just running cases, reviewing cases and care of patients every single month really helps us to make sure we're just giving the best care that we can. This is our fetal demise treatment algorithm. So when the patient when the patient presents to the emergency department, if they're greater than 14 weeks with an imminent delivery, we would keep them in the emergency department and delivery would take place there. Greater than 14 weeks without imminent delivery, we would transfer those patients over to L&D for that special delivery process. And then if they are less than 14 weeks, they remain in the emergency department, and we consult at labor and delivery as needed. And then this is our new postpartum triage algorithm that we kind of just are working to put forth in the emergency department. So it's nice and colorful. And it definitely shows if they're less than 20 weeks gestation, they can be treated in the ED with consultation as needed. It's basically the same as what the other one stated, but it's just got some different types of treatments on there. So I wanted to speak quickly about, we had the opportunity to work with a midwife student from the University of Kansas. Her name was Cassie Cato, and she helped to develop a new policy on pregnancy loss in the emergency department. So she's currently employed at our Advent Health South Overland Park campus. And she developed education and came and spoke at one of the staff meetings and developed a resource binder with the whole process of early loss in the emergency department. It was based on losses less than 14 weeks that would be appropriately treated in the emergency department. And then she developed a whole policy that's pending approval by certain Advent Health committees right now. But this allowed families and patients experiencing the loss of pregnancy or fetal death in the emergency department to receive the best physical, emotional, and spiritual support. And the reason I think that's so important is because obviously the emergency department is a very fast-paced environment. We do deal with critical patients, and sometimes we just aren't as in tune with how to provide overall care for such a traumatic situation, such as an early loss. This also ensures that team members caring for patients will provide privacy and be respectful and compassionate in their care. It just really brought forth some different types of scripting and different types of care that we can provide the special population. Families also would be assisted in determining the disposition of any remains, and that they would be handled in a dignified way as well. Up and coming in the emergency department skills day, we have an annual skills day, and so we are going to be reviewing this policy. It's in November this year, so we'll be reviewing the new policy, going over the binder again as well, and then also making sure that our staff knows where our Bridget's cradles are for that exact process.
And just to tag onto that as well, I think one of my favorite components of that are for those patients experiencing an early loss, for them not to just sit out in the main triage area, because I'm sure we've all experienced before, you have someone out there who is bleeding, and the last thing she needs to do is to stand up and then walk from, you know, area A to area B, without the privacy of being able to A, monitor how much she's bleeding, and B, not have it exposed. So we have a private area once you get into our triage area where that mom can go, and there are chucks there, and she can be there where a triage nurse is not far, to where if things become excessive or she just needs any help while she's waiting to be seen, she has that opportunity too. So I was really grateful just to have that conversation with the ED staff and for their willingness to work through it with us. The slide that you guys are looking at there, I'm sure you've all seen before, CMQCC's treatment algorithm of the hypertensive emergency. This was embedded in what we call ALN, it's our Advent Learning Network. Some people use HealthStream, whatever web-based education materials you guys or resources you guys use. We put together a whole PowerPoint presentation online for our emergency department staff. I was really surprised, and it was a big eye-opener for me to know how many patients would come through the emergency department with blood pressures of over 160, and they wouldn't bat an eye because they're used to that all the time. Whereas I would have a heart attack and say, what do you mean? You just let her sit there, you know, that she's going to see. So getting that information across to not just the nurses, but our medical director did an education session with the emergency department's physicians too, to make sure that they were more in tune with the parameters that were more severe with the obstetric patient and the postpartum patient as well, and knew that the correct algorithm to treat. We had experienced patients before who had just been put on MAG but never received any antihypertensives, or been put on MAG and it wasn't the correct dose that they were supposed to get for their bolus or things like that. So making sure that this education was conveyed was a big move for us. Next slide. In addition, ensuring these next two slides were conveyed, how do you handle if the patient becomes eclamptic? What were everyone's roles in that situation? Who to call to make sure we get everyone to the table who needs to be there, and that we're managing it in the correct manner. Next slide. This next slide is a very similar but more colorful algorithm of who needs to be involved in the treatment or management of the eclamptic patient. Next slide, please. And then our maternal warning signs. In addition to training all of our labor and delivery mom, baby, and NICU nurses, we also reached out to the ED staff, and it was a big undertaking to make sure all of their staff were trained. So we started with just what we would call our CNCs here, our clinical nurse coordinators, or some would just call them their charge nurses. So we made sure that all the charge nurses in the emergency department received that training, and then that was trickled down in a train the trainer manner, so that the staff was all educated on what were the warning signs, and more importantly, again, consistently ensuring that every patient every time was asked, have you had a baby within the last year? Just so that we knew if they had any of these symptoms, to make sure that they were a priority red flag for us. Next slide, please. And then this is our massive transfusion protocol per se. Again, we love some color over here, so everything has to be colorful and bright. But we shared this with our ED staff in the event that they were to encounter a pregnant or postpartum patient. We are not a trauma center. Mallory can speak more to that, as Overland Park is, but our ED doesn't on a routine basis have to activate the mass transfusion protocol, but it's something that we utilize in OB much more frequently than we wish to. So just making sure they knew the process, how to correctly enter that order if it needed to be done, what medications were available. Our emergency department doesn't stack any of those medications. So the big thing was to ensure they knew to call an OB rapid response, and they were aware of who was going to come in that event. In the same way, if I have a prospective STEMI or something like that that's coming through OB-ED, I want the right people to come and manage that. They were educated just to call an OB rapid, and our team would come. We would bring our hemorrhage cart. We have all of our meds available with us in that moment and can respond quickly to take care of that. The same applies to a code imminent delivery. We make sure that our emergency department is stocked with our preset packs, but for them not to think that they have to manage those deliveries alone. We have a NICU team who comes down. We have a warmer that stays down in the emergency department in the event that that happens. And then we respond to all of those calls. Abby's going to speak to the next exciting collaboration that we do.
Okay, so we at this facility have done some pretty amazing, if I can say and brag a little bit, simulations within ED and OB. You can go to the next slide. So this is the imminent delivery sim that took place in the ED parking lot, or in the bay of the emergency department. You can go ahead and click that link. It should play. If you click on the video itself. Maybe, hopefully.
Oh, it worked last night.
Do you see it on the screen?
I think if you hover over the actual sim picture, it'll show a play in the middle. Maybe, oh no.
What if you right click? Because I see it on my screen.
You do see it on the.
Okay, well now we're sad, but we're gonna
That's
we're gonna
okay.
punt this and roll with it. I will go ahead, Abby.
This actually took place in Carrie's van. She had, wasn't this your van? Yes.
Yes, and my husband was less than thrilled about the fake blood that ended up on the seats of the van afterwards. So it was a one and done opportunity, no more after that.
Yeah, and it was just like they presented this, pulled up in the emergency department bay with a woman who was, I think it was gravida 4 in active labor. So it was very, very good to see how quickly people responded, and that they knew what to do with the situation. So that was the one that took place there. This next video and simulation was over a 20-minute simulation, and it had one of the, was that the OB hospitalist? Is that the OB? Okay, OB hospitalist and Faith, one of the educators here. They did a full birth within one of the rooms in the emergency department. So it was an imminent delivery sim here, and you can see him getting set up in that first picture, and then the baby is born in the second picture, and they're kind of stimulating. And you can go to the next slide. Then they did skin to skin at the same time as the cord was clamped and cut. Next slide. this one here shows the placenta on the right. I think I might have should have put the placenta in a different spot, but here's the placenta here. The one on the left is actually that's Carrie in there, and this one actually is describing a shoulder dystocia, how to have an imminent delivery with that. The sim also, we didn't want to put too many pictures on here, but it also showed like a couple different other critical situations that might happen, breech birth, things like that. So it showed just each step of the process and how to care for the patients.
And this was actually recorded, and it's on the education department's intranet page. So they can use these recordings for all new staff that are onboarded. And just want to highlight, we dressed Victoria up. So it was Halloween. She's in her Cleopatra costume, in case anyone's wondering what she was wearing at the time. So she was coming in on Halloween night from a Halloween party and was going to go ahead and blow out her baby in the emergency department for us. A little too much fun she was having, but I love that our laborist went through and she described what to look for when you deliver the placenta if we hadn't gotten down there in time to ensure you don't have any retained parts. Just a lot of good times, which I appreciated being invited down there to do this, and that we get to use these videos over and over to educate all new staff who come on board.
Yeah, they're very helpful.
Next slide, please.
And then we have some planned upcoming simulations within the next year. We want to do a precipitous delivery or imminent delivery at the outlying emergency departments, Lenexa, College Boulevard, South Overland Park. And also on the radar is a maternal hemorrhage simulation that we would want to have completed. And then postpartum hypertension or eclampsia. And then we also, as we kind of know that within that full year after the birth of the baby, that's your 4th trimester. And we know that we need to be screening a lot more for anxiety and depression. So we would really want to implement a postpartum depression or psychosis type of simulation within the next year as well. And I know that, just as a final little thing, we have a new educator here in the emergency department here at Advent Health Shawnee Mission. Her name is Lauren Stillwell. We are working to have a specific 2 to 4 hours in our orientation days to go over OB and labor and delivery processes, to really educate new staff coming in the orientation phase on all of these really critical things to watch for. And also we want to set up a day where we swap. Labor and delivery sends one of their orientees over to the emergency department to see our workflow, and we send one of our orientees over to labor and delivery to see what their workflow process is. I think it builds camaraderie, understanding, and a little bit of patience between the two departments as well when you've been in their shoes and you really understand what they go through on a daily basis.
This is where we tee you up, Mallory. And Mallory, you get to now talk about all the amazing stuff that you are doing with your perinatal outreach program.
Yeah, thank you for having me. So like Carrie introduced me already, my name is Mallory. I'm the outreach coordinator for Overland Park Regional Medical Center. Next slide, please. So what is the program? As it's been previously mentioned, and we all know, maternal mortality rates in the United States have continued to increase year after year, with the most recent data showing mortality rates at 32.9%, 32.9 deaths per 100,000 in 2021. So this program was actually developed to educate and provide support to providers and staff of other facilities and departments throughout Kansas and Missouri, really striving to enhance learning and growth and promote advocacy for consistent standards throughout the region, hopefully to drive down those maternal mortality rates. Next slide, please. So this is just kind of a snapshot of the area that we currently serve. We travel in about a 160-mile radius around the KC metro area, supporting different units and departments and facilities with varying types of education. We currently support about 40 different hospital units, departments, emergency rooms, freestandings, EMS departments, fire departments, all of that is inclusive in that number of 40. And to satisfy the different learning styles, we offer education in terms of like lectures as well as simulations and hands-on things. We have a virtual reality component, escape rooms, that kind of stuff to really kind of bring in different learning styles and make it fun. Our team has, highly qualified and certified experts that go out, and we really hope to customize and really meet the demands of the needs that are being requested. Next slide, please. We currently have about 40 people that work within the program. I am the only full-time person currently. The rest of them are PRN, but all qualified and specialty certified. For the most part, 93%, that's pretty good. Holding at least one certification, lots of education and experience, including higher learning degrees as well. Next slide, please. So what we offer, we currently have 13 hands-on simulation events, and then we also do 11 different didactic or lecture type courses. And that again is to satisfy all the different types of learning styles that we have, and we do combine simulations and classes as needed. We believe that simulation is not an evaluation of personal performance. Instead, it's an opportunity to practice skills in a safe place, looking for opportunities to improve processes and protocols. Our simulations involve hands-on participation while working through a scenario and interacting with simulation equipment. And that equipment can include high fidelity simulators, low fidelity simulators, computers, monitors, vital signs, lab reports, mock medications, that kind of thing. All of our didactic courses involve lectures that follow a predefined agenda and meets established objectives, and our educators are trained and have to maintain minimum competence through whatever authorizing organization. For example, A1, we use their fetal monitoring, so they have to meet the needs to maintain their instructorship. Next slide, please. So why this is important, Carrie touched on this a little bit already, but for the March of Dimes, 36% of counties nationwide, largely in the Midwest and South, constitute as maternity care deserts, meaning that they have no obstetric hospitals or birth centers or no obstetric providers. So this is a big deal. Last month, CNN actually published an article that said that the rate of death of patients admitted at the time of delivery has decreased by over 50%. And they were kind of celebrating that, which is, that's great. However, when you look at the maternal mortality rates overall, those numbers are climbing. So what does that mean? It means that patients aren't dying in the hospital when they come in to have their babies. And 53% of the deaths that are occurring for moms are occurring 7 to 365 days postpartum. So this is an issue that really does involve our EMS and our ED staff. They have to be involved with the education and training that we're providing, because a lot of these patients are coming to them. Next slide, please. So what do we do specifically for ERs and ED, EMS, fire departments, first responders? These are the top 5 simulations and activities that we do: precipitous deliveries, newborn stabilization. We also go over hypertension and pregnancy, as well as postpartum hemorrhage, and then maternal code. And all of these are simulated in their own environments. And then we also do go over the protocols that are out there. We use all of the CMQCC, ACOG, SMFM protocols. We do not actually take out, we will share our protocols from Overland Park Regional. We're happy to share information and then, allow places to tweak it and make it their own. But in terms of, evidence-based practice, we really provide that evidence from those governing bodies to say this is what, is recommended by these higher levels. And then we can share our protocols and say, this is how we implemented this in our facility, if you need to make adjustments or suggestions. Interestingly, I think what I have seen throughout my work with emergency departments and EMS, number one is the screening that I know Carrie and Abby have both kind of touched on. Have you had a baby in the last year or been pregnant in the last year? Most places that I actually, unfortunately, interact with, they aren't screening. I think that's an important thing. Also, that little caveat of childbearing age. What is childbearing age? And who do you ask? You can't really make assumptions based on appearance or, how old you think they are. I think the world record for the oldest person that delivered a baby was, I want to say 78, if I remember that correctly. I looked it up at one point and she had twins. So you just cannot assume anymore. And so I always tell people, if you have somebody that has a uterus, you probably need to be asking that question, and just rule it out. If they answer yes to that, then we need to assume this is a pregnancy complication that they are presenting with until that is ruled out. So I think that's really kind of an important piece that I try and relay to these, these colleagues of ours that we have out there. Sorry, I saw something on the chat. Was there a question? Oh, no. Okay, yep, next slide. You got it. Perfect. So if anybody has questions on how I, format my trainings, or obviously we customize this to the participants that we have, and also the resources that they have. So there's really no point in going in there with, supplies for, certain procedures, or, for example, in our emergency departments, most of our ED staff are not going to be placing UVCs in babies. That's a specialized skill that needs to be trained and learned. So when we talk about kind of resuscitation, we talk about what is important for that particular facility to know to stabilize, and what kind of resources do we need to initiate, or what calls need to be made, and what consults need to happen for these patients.
Valerie, I think that's so true. It's not that all of the information that we provided is what has to be done at every facility, because you're right. Every facility has its own unique set of resources and needs. And it's just important to know what is the quickest way that you can get the people who know what to do to the area in that moment. So we wanted to thank you both so much for that. And we wanted to take this opportunity, and we have a few extra minutes because I'm sad our video did not work, but we wanted to open it up to any questions, if there's anything that we can answer or share with anyone on today's learning forum.
I would just like to talk. Mallory is technically here at my hospital right now. And we have been doing simulations, and it has been phenomenal, because rural critical access hospital, and we are doing amniotic fluid embolism today, which scares the heck out of everybody, but just a great experience for our nurses, because we don't see wild and unusual. We're very low key with our patients, and these things can happen. And so it has been very beneficial to our facility to be having her come.
I love it. I love it. I've had the privilege to watch her in action as I've traveled around to different hospitals with her too. And it's fun. It's fun to see nurses from all over get to benefit from the information that she shares. And I think it was a great experience for me to see what other facilities are doing too, because just like when you learn different things from different preceptors, you kind of pick, different things and take it back to your facility and create your own practice. I think she does an amazing job. So Mallory, do you want to speak briefly to what you're doing with the AFE Foundation as well too? Because I think that's important.
Sure. So they actually just launched their education bundle, which was a collaboration between the AFE Foundation and Clinical Innovations Critical Care Obstetrics, which consists of some, very like prominent people throughout A1 even, but Suzanne McMurtry-Baird, Dr. Stephanie Martin, and Julie Arafay, who is a simulation specialist. And they put together this amazing education bundle, which is now available. It's free of charge, on demand. You can log in self-paced. It's, I think, 4 total modules, and there's little lessons in each module. Free CNE credit for that. You get 3 hours. So it's well worth it. And then I actually collaborated with Julie Arafay and the Amniotic Fluid Embolism Foundation, and we created a simulation toolkit, which is also available free download on their website. Really kind of going over how do you put together a simulation over this, hugely traumatic, catastrophic event. And, what are the key components that you want to look for when you're developing this simulation? You don't have to have the multi-million-dollar high fidelity simulators to do this. There's a few key concepts that are really important to make sure you embed within that education. And so we developed the toolkit, went step by step over what needs to be done. And they worked very closely with me when I developed my actual AFE simulation that we used for the outreach program. We developed it 2 years ago when I first started. We incorporate, generally speaking, we incorporate survivors into our education so they can talk about their experience and share key parts of their stories, the events that took place, and what kind of impact that had on their journey. So we oftentimes do have them, which I think is a very moving part of the experience, to kind of have that ability to talk to somebody about it. But we have been able to really increase our participation of multidisciplinary involvement with simulation. And I do think that particular topic is part of it. Everybody's interested in it. Everybody wants to learn and simulate this one. Not that the others are less important, because they're not, but it is sometimes harder to get some of the other disciplines involved with, postpartum hemorrhage that we simulate 3, 4, 5 times a year. And we do it also routinely all the time on the floor. So some of these more rare events are a little bit easier to get the buy-in from some of the other players that we want to have an part of our simulation and education. In addition to that, we've been able to kind of get more of them involved with some of the other simulations as well. So once they come and see what we're doing with amniotic fluid embolism, then we're able to usually hook them and keep them involved with other simulations.
I love it. I love it. Love it. And I love that you're at Dana's hospital right now.
Yeah, she's, I think, just across the hall.
That's hilarious.
Yeah.
Does
Melanie,
anyone else?
I
Go ahead,
just
Abby.
want to say, as a person from rural Kansas, thank you so much for all that you're doing outside the urban and suburban area. That's a huge geographical area that you're servicing, and I can't commend you enough. That's awesome. Thank you.
Well, I started my career at a small rural hospital down by Wichita. So I have a soft spot in my heart for the rural communities. And, I just think the world of the nurses at these hospitals, honestly. If you want to meet some badass nurses, oh, can I say that? I'm sorry.
You just did.
I did.
Too late.
These nurses are, just incredible. So I love coming out to these hospitals and doing what I do. I love going to the fire departments and the emergency rooms. They get a little timid when I first walk in with all my stuff and this mannequin, and they're like, what are we doing? But they get into it. And I think, making it applicable to what they do is a huge part, and what role they play in this patient's care. When you make them recognize, like, you actually make a huge impact on what happens with this patient. I think that's that really makes a difference.
I love that you mentioned the importance too of low fidelity, because it can be pretty
Mhm.
intimidating when we love to throw up all of our big equipment and all the stuff that we do with the resources that you
Mhm.
have, which we all know costs money. But I've traveled to third world countries and done postpartum hemorrhage education with barely any resources whatsoever. The point is we get this information out. We figure out how to work together. And interdisciplinary wise, and we get the information out, because we can't fix the problem if we don't. So if there's anything that we can help anyone on the call with, if there's any algorithms, or if you are working with your emergency departments to try to extend that collaboration, if there's anything we can do to help you not reinvent the wheel, I think the important thing is just to take the step and reach out and let us know how we can support you in that. And with that, I'm going to punt this back to Tara.
Wow, the bus just went straight over me. Hey, I just want to say thank you. We're all communicating around you all about our next steps at our individual and regional levels. And listen, you guys, to Abby and Mallory, thank you so much. I honestly think this could be an entire conference, which we should do. But thank you to everybody that joined us, and we look forward to seeing you next month.
Have a great week, everyone.
Thank you.